Hey everyone, this is Mrs. Lewis. I'm going to go over shocks, and I'm probably going to be going over it pretty fast. I want to try to get through this within 30 minutes, but it may be a little longer. Apologize for that up front, but I did want to give you as much information as I could for this content to help you focus and understand it a little bit better as far as the concepts. So let's get started. I've got it labeled as shocks, but we are going to go over MODS a little bit and SIRS as well, which are, pretty different things, but they are related to shocks. They can be related to shocks. So let's get started. So what is shock exactly? Shock is just a syndrome characterized by decreased tissue perfusion. That is what it is. And usually, because of this, you get an imbalance in supply and demand for O2 and nutrients. So you've got a problem, you can't get the organs perfused, so therefore what goes to the organs but blood and fluids. So if you're not getting those, you're going to have an imbalance in oxygen, because what goes with blood? Oxygen, and as well nutrients. So that is what shock is, for just an overview of it. And then how do we classify shock? Well, there's different types, and one of the types is cardiogenic. So cardiogenic is more of a pump problem, right? So we got a problem with our pump. It's not working properly, or the heart's too weak, which is, the heart is the pump, so it's too weak. So we've got a pump problem. And then hypovolemic is more of a pipe problem. There's not enough fluid in the pipes. And it can be absolute or relative. And all that means is absolute just means what it says it means is an absolute loss. There's either a lot of bleeding, so like hemorrhagic, or there's fluid loss, GI, such as diabetes insipidus, or stomach virus, and they're vomiting a lot, or somebody's first becoming a diabetic, or anything really where they're losing a lot of fluids other than blood. So that's absolute. And then relative is just when the fluids shift. So think about your burns patients, or it could even be your ascites, like we talked about with the liver. And that fluid shift. So basically third spacing would be more of your relative, and then distributive just means there's a distribution problem. There's nothing wrong with the pipes. There's a distribution problem to get it to the heart and to get it to the body. So that's usually when you get this inflammatory response and the blood starts just kind of pooling in the vessels. And as far as what falls under this distributive would be your neurogenic, it would be your anaphylactic, and it would also be your septic. And we're going to talk a little bit more about those, but those are your distributive shocks. And then you've got your obstructive shock, and that just means exactly what it says it is. It's obstruction. There's an obstruction that is blocking blood flow, or causing a problem to block blood flow. So that would be like your pulmonary embolus. That would be a good example, and we're going to talk a little bit more about that. But those are your different classifications of shock. And then we've got stages of shock. And your different stages of shock, you've got your initial. So this is like right in the beginning, your body is responding to whatever the underlying cause is, and the tissues become underperfused. So there's a decrease in cardiac output because of this. And then there's an increase in your anaerobic metabolism because of the way the body tries to stay in homeostasis. Well, that can't continue, right? So we go into a compensatory stage. It is reversible at this point, and your compensatory stage can go as early, it can happen as early as 30 seconds. I know there's a lot of gray area here, but it's basically the body's compensating this in this stage. That's when your body releases those neural and hormonal and biochemical physiological compensatory mechanisms to try to maintain, to overcome acidosis and try to maintain that homeostasis. So your sympathetic nervous system, or your autonomic, the whole autonomic nervous system kicks in, and your sympathetic nervous system kicks in, your renin-angiotensin aldosterone system kicks in as well, and you're going to see some vasoconstriction to get the blood to the kidneys so you can have some urine output. But because of this, you will see decreased urine output. Decreased blood pressure leads to a decrease in perfusion to the kidneys, leading to this RAS response. That's why the RAS happens, because of it's a mechanism created when the body senses low perfusion to the kidneys. There's a couple of different ways it can happen, but when the RAS response is kicked in, you get this vasoconstriction, and then a release of epinephrine and norepinephrine from the adrenal glands to constrict, so that the vessels can shunt the blood to the most essential organs. So that's what the RAS system does. This is the compensatory mechanism in a nutshell. And there's some other things, we get a release of aldosterone, a release of ADH. So this is our body's way of trying to compensate. But it can't do that forever, so then we'll start getting some failing compensatory mechanisms, and then you'll see this profound vasoconstriction because it's trying so hard, right? And ischemia can occur because lack of blood flow causes ischemia, right? Then we get this lactic acid that continues to build, and you get a metabolic acidosis. And then as it gets on further, you get into this irreversible or refractory stage. I gotta learn to talk, don't I? Where you will see some cellular necrosis and the MODS, and a lot of times death is imminent in this stage. So these are your stages of shock. Let's talk about the shock. So cardiogenic, what is it exactly? Well, it's poor myocardial contractility. Whatever is causing that can cause a shock. So is it heart failure? Is it CHF? Is it a heart attack? Someone's having a heart attack. They've got a blocked major coronary vessel. Well, we talked about this for test 2, right? Sympathetic nervous system kicks in to try to keep homeostasis, and what's going to happen is they need to get to the cath lab, right? That's the whole purpose in that 90 minutes. We want to intervene because we want to prevent them from going into cardiogenic shock. That's the whole purpose. So if we don't intervene with this blockage and there's not enough blood flow, we're going to see the evidence of shock. Increased heart rate, decreased blood pressure. That's what we're going to see. And what else do you think we will see? Well, with cardiogenic shock, if we're not perfusing the body, we're not perfusing the kidneys, so we're definitely going to see some lack of urine output. So as we see lack of urine output, we're going to see lack of urine, and that's called oliguria, which is decreased urine output, less than 400. And what is our normal urine output? Well, it's 30 milliliters an hour, right? So if we don't have that, then we know that our patient's not perfusing very well. They're not getting the adequate blood flow to the kidneys. We will also see some tachycardia, of course, that's a given. We could see bilateral coarse crackles because of the heart's not pumping the blood adequately, so we got a backup of blood into the pulmonary vasculature. So we have to be careful with fluids in this population. We have to be careful with giving fluids. So just remember, Use fluids cautiously, and we got to treat the cause. So if they need to get to the cath lab, then we got to get them to the cath lab. So treat the cause, and we're doing I's and O's hourly. So just remember that. We've got to do those I's and O's. They're most likely going to be on a central venous pressure monitoring. They're going to be on hemodynamic monitoring. We're going to probably have an art line in them because we need ABGs. So just remember the heart is weak, and there's really no loss of fluid. So we have to prevent volume overload and worsening heart failure. We might need to treat with diuretics, but again, we got to make sure the kidneys are working right if we're treating with diuretics. So that is a treatment if the kidneys work enough to use them. But also you might have to use a positive inotropes like dobutamine, dopamine. We might have to use afterload reducers such as nipride or nitrates. Remember, nitrates cause vasodilation, and it'll open things up so that the blood can get through. So nitrates is a good treatment. Also, it decreases the workload of the heart, and therefore you're going to have decreased myocardial oxygen demand. So they could even do nitrates and an inotrope. So remember that. And then also remember we talked about the intra-aortic balloon pump. That's a way to help the heart get the blood to the body. If the heart is weak, if the pump of the heart, the left ventricle is weak, they might need to use a ventricular assist device. So that is your cardiogenic shock. Remember, use fluids cautiously, and we got to treat the underlying cause. Your hypovolemic shock, what is it exactly? We've already talked about it a little bit. It can be relative or absolute. When we talk about absolute, we got to think about, is it a fluid loss? Is it a blood loss? Because if it's hemorrhagic, we're not only replacing with fluids, we're replacing with blood products. So just, remember that as well. And if it's relative and a burn, we may have to treat with plasma. So, just remember that we have to treat them with IV fluids, and a lot of times it is normal saline. But also remember, they don't have enough blood in their pipes. So what might we see? We definitely might see some anxiety, restlessness, weak, thready pulse for sure. And we could even see some new onset confusion, because remember, especially if they're losing things and we're needing to watch their fluid and electrolytes, then we might have a problem with low sodium or high sodium, and those both can cause confusion. So we need to look for that type of thing as well, making sure we realize their electrolytes need to be monitored. And then also look at their skin turgor. Same thing with them. Oliguria. Are they urinating? Are they getting blood flow to the kidneys? Are they getting enough blood flow to the kidneys? And then, of course, we're treating them with IV fluids, with blood if we need to fill the pipes, if there's a blood, a hemorrhage, and then also pressors possibly. So with hypovolemic shock, same thing. We need to get the fluid back to the organs, right? If needed. But again, we're still treating the underlying cause. If they lose a bunch of blood, we're giving them blood. So that is your hypovolemic shock. And then let's talk about neurogenic shock. What exactly is it? Well, it is basically an injury, right, to the spinal cord, usually above T6, and what happens is a spinal cord injury. They lose the ability, below that injury, they get, flaccid paralysis, and they have absence of reflexes. So what happens, they still have that kick in of the sympathetic nervous system. It still tries to kick in and keep the body in homeostasis, but due to this injury to the spinal cord, and loss of vasomotor tone, then the heart rate doesn't go up. The blood pressure goes down and the heart rate goes down because of this loss of vasomotor tone, and it can't, it just, it won't go up. So this is distributive as well. There's enough blood, there's enough fluid, but the pipes, it's just not enough to distribute it. So we might even use pressors with them. We do use fluids, normal saline again, and we do often use them cautiously because we're not missing fluids in the pipes, but that would be what we would use if we needed to give them some fluid, especially for blood pressure. C-spine and ABCs, remember, monitor for hypothermia because they can have the poikilothermism as well, and we have to support that spine so that we don't create further injury. So just remember that. It's a good thing we've already studied neurogenic, we've already studied cardiogenic, so these are kind of a review for you, but definitely know them. And just revisit all of this and understand it a little bit. With anaphylactic, this is new for you. What exactly is it? Well, it is usually caused from some type of allergen or antigen that leads to a life-threatening hypersensitivity reaction. So a lot of times these reactions can occur over time or immediately, but you build up this sensitivity to this allergen or antigen, and you will eventually have an anaphylactic shock. I can give you a first account of that. My daughter's allergic to nuts, and her initial reaction was just some vomiting, but the doctor gave us an EpiPen. We went and did all the testing, and he said, you're going to need this because it could get worse. So over time, they usually get worse, and then some people, it's just worse immediately as far as going into anaphylaxis. So it can be direct contact, inhalation, ingestion. Like I said, it can be food, it can be drugs, it can be chemical, it can be a venom as well. So, just remember that. But your T cells recognize this antigen from a previous exposure usually, and then they initiate that inflammatory response. Remember, we talked about that. It's a distributive shock, so you get this inflammatory response. Then you get these vasoactive mediators like histamine, cytokines, heparin. You get this massive vasodilation. Then the peripheral blood starts pooling. You get increased capillary permeability. The fluid starts to leak. So it's kind of the same concept with these distributive shocks. And this can progress rapidly. I often, we carry an EpiPen with her allergy, so most of the people carry an EpiPen. And first thing I do, if I don't, of course I don't carry my stethoscope with me everywhere, I will listen to her throat, I'll listen to her chest. I'm looking for stridor, I'm listening for wheezes, because I'm trying, we want to intervene as quickly as possible, so you give the EpiPen and you call 911 is usually what you do. But you're assessing that airway because that edema and that laryngeal edema can come on pretty quickly. So that's why we assess while if we suspect this could be occurring. The clinical manifestations, they might feel like this impending doom. They might get a little itchy in their throat. They might say my stomach hurts, trouble breathing, like I said, stridor, wheezing, GI cramps. They might vomit, and a lot of times when she does vomit, it'll just be like clear mucousy stuff because those are the histamines kicking in. they could have chest pain, and definitely some edema, swelling of the lips. Sometimes her throat will swell, but her windpipe won't swell. It's the weirdest thing. So everybody is different, but we got to treat them all, with an EpiPen, and often we will give them fluids as well because it's a distributive shock, but it's not like they need a bunch of fluids because there's not anything wrong with the fluids in their body. There's this massive inflammatory response going on. So we treat them with Epi, and we will often give them Benadryl as well, diphenhydramine, and then corticosteroids. So think about your methylprednisone, your Solumedrol, and then your H2 blockers such as Pepsid. Now, when I say H2, it's not PPIs, it's H2 blockers. You want those histamine blockers with this type of shock because you're blocking that histamine reaction, because that's part of the problem, that histamine's released in response to this allergic reaction. And with the histamine release, you could even have some itchy skins, hives. If she ever gets peanuts or nut powder even on her, sometimes she'll break out into hives. So it won't cause if it gets on her skin, it won't cause anaphylaxis, but it does cause hives. So with this, we're trying to prevent intubation, because really they can't intubate them. If the airway swells, they have to do a trach, and so that those corticosteroids will help prevent the inflammation, or help it not be as bad. And then your Benadryl or your diphenhydramine is an antihistamine allergy medication. So when she's had a reaction before, we do the EpiPen, we go to the hospital, and they usually will do Benadryl IV, they'll do Solumedrol IV, which is corticosteroid, and they'll do a piggyback of Pepsid. That's usually what she has gotten when we have had to go to the emergency room. So that is pretty much the anaphylaxis. Just remember, airway, monitor those lungs, listen for the wheezes. And let's talk a little bit about obstructive. It's basically what it says it is. We got to treat the cause. If it's a PE, we got to treat it. If it's cardiac tamponade, we've got to treat it. Early recognition is key here. So that is your obstructive shock. All right, let's talk about septic shock really quick. This is kind of a review, but it's basically, what is it? It's an invasion of microorganism. And it's usually gram-negative. It can be gram-positive. It can be fungi. It can be parasites. It can be viral. But it can, all these things can cause an infection or cause a problem. But most of the time, it's caused by an infection. And all of these things down here can definitely cause, right here, indwelling medical devices. What we're trying to prevent when we take out those Foley catheters early, we're trying to prevent a patient, we're trying to prevent SIRS, but we're also trying to prevent sepsis in our population at the hospital as well. We remove caths early, we use aseptic technique, we use sterile technique, and we are careful with our invasive lines. Often with septic shock, the urosepsis is often the cause of it. And we have to again treat the underlying cause. So you want to think about that hour bundle where we're doing the antibiotics within an hour. We're drawing those blood cultures. And we're keeping that MAP equal to or greater than 65. So we're doing the fluids, and if that doesn't work, we are going to definitely do some pressors. We're drawing the serum lactate. That's part of our hour bundle, the lactate level. And our QSOFA is basically an organ failure assessment to help us realize, okay, we're trying to figure out if this is going to turn into shock on the floor, not necessarily ICU. So that's where this Q-SOFA came in. They were trying to figure out a way for us to get on like med-surg to be able to recognize early problems before they get to ICU, so that we can call a cold rapid or call the doctor and intervene. So this is for someone in a known infection, Q-SOFA. Don't forget about the hourly bundle. We got to measure that lactate level, obtain blood cultures, administer the broad spectrum antibiotics, and rapidly infuse 30 milliliters per kilogram of a crystalloid. And this is definitely for, this could vary here for hypotension or lactate level greater than 4. This could vary per hospital policy, but that's just a general rule there. And we usually remeasure that lactate. If it's elevated, we'll remeasure it again in 3 hours. That's part of the 3-hour bundle. So let's talk about SIRS. So SIRS is a criteria we use as well, but SIRS is a thing. It has its own little definition. Okay, it's often related with sepsis, but because of infection. But as you can see, there's plenty of other things that can cause SIRS. SIRS is that systemic inflammatory response to a suspected or documented case of infection, but it can also be a systemic inflammatory response to a variety of causes. You've got infection, ischemia, multiple trauma. So you want to think about your crush injuries, tissue injury, burns. When I say crush injuries, I'm talking about like a MVA, and their pelvis is crushed and their legs are broken. That is some massive damage to endothelial. It's widespread endothelial injury. It's tissue edema. So a lot of things contribute to what happens with a crush injury. So tissue injuries such as burns, hemorrhagic shock. Hemorrhagic, that's loss of blood, right? So when you have that massive amount of loss of blood, and then an immune-mediated organ injury. So think about the immune response. And then also I want you to make sure you review in your books, it's a table 6610, and that talks about the manifestations of SIRS and MODS, and just read about in your book about SIRS and MODS so you really understand it. As it is, they are standalone. They're not, we usually talk about them with sepsis, but they are also standalone type things. So definitely read about it. As you can see on your blueprint, we have we have some questions just for those things. So make sure you read about those in your book, and I'm going to talk about them a little bit more now. But as you can see on I like this table here, as it does talk about the SIRS criteria, and it talks about the Q-SOFA. With your SIRS criteria, though, remember, we're looking for criteria for the systemic inflammatory response. Maybe they have a burn. So if you hear a SIRS alert, it doesn't necessarily always mean sepsis. It could, because sepsis is infection, but it doesn't always mean that, because it's just that inflammatory response. And so many things, even just surgical procedures can trigger this SIRS response. But as you can see, your temperature, low temperature or high temperature, and remember 100.4 to 101 is actually considered a fever. If you got somebody with a 99, they don't usually consider that. So make sure you don't think we know what a fever is. And then your heart rate of greater than 90, respiratory rate, and then don't forget about your white blood cells, 4,000, which is low. So think about your immune compromised people, your HIV, your cancer patients. And then also they're really high, so infection again. Then also don't forget about your baby neutrophils, right? Your bands, your baby bands. So if you've used up all your neutrophils, which are your fighting cells, right? Then you're going to see some bands, and that just, sometimes they call it a shift to the left, because if your bands are greater than 10%, then you've got a pretty widespread infection going on, because you're using those baby neutrophils. So remember that. So what do we do for MODS management? Well, we want this. So what? So we talked about SIRS, and SIRS is that inflammatory response. Well, what is MODS? MODS is multi-organ dysfunction syndrome. Multi-organ dysfunction syndrome. And again, read about it in your book so that you understand it. But it's usually a severely ill client who is hemodynamically unstable despite fluid resuscitation attempts, and sometimes despite pressors, and sometimes the pressors are the only thing that's keeping their blood pressure. So most of these symptoms, SIRS and MODS, are respiratory. Our respiratory is the first system to show signs and symptoms. So, making sure that you're listening to the lungs, reassessing the lungs, and knowing, in your mind, you got to kind of have this anticipatory thinking, right? As nurses, we have to think ahead. Like our patient, we have a patient that's brought in. They've had recent surgery, they're back now, and they have a paralytic ileus or something like that. We got to think in terms of, what is the worst thing that could happen. So if we're thinking ahead and we get early intervention, that's the thing with this, with these our goals to prevent MODS is that detect that early dysfunction, that early organ dysfunction, and early intervention. They have such a better chance. So that's why it's so important for us to always be on our game and to always be thinking. So, what are some clinical manifestations? Well, first let's talk about early recognition. Well, early recognition, like I was saying, we got to recognize, okay, our lungs are changing, our creatinine's creeping up, what's going on here? We need to get those blood cultures. We need immediately. We need imaging studies. If it's a spinal cord injury, we need to get them. We need to get some imaging. We need to know the source of the infection. If it's a MI, we need to get them to the cath lab. We need thrombolytics. So we need that early recognition and intervention. And then we need that early hemodynamic resuscitation so that we can have perfusion, right? We need to perfuse the organs. We need to perfuse the kidneys. So we've got to have that early hemodynamic resuscitation, meaning we need for fluid, right? We need IV fluid. We need possibly pressors as well, vasopressors. And then we need early and adequate antibiotic therapy. Remember that 1 hour bundle for sure. And then that continued hemodynamic support. They're going to, remember, they probably will have an art line so we can draw ABGs. They will also have a central line so that we can centrally monitor them and do some hemodynamic monitoring. We can monitor their CVP, because remember, we want their CVP. With fluid resuscitation, we need their CVP up. We want to pump them up, basically. And we need it greater than the norm. So remember, the norm is I think it's 2 to 8. So we want it 8 to 12. And sometimes with hypovolemia, we may even want it higher than that, maybe 15. But the main thing is we want it more. because a lot of these patients, they either have pooling in the vessel or they don't have anything in the vessel, in the pipe, so we need that fluid resuscitation. And then we want their MAP equal to or greater than 65. We want urine output. So, Q hourly. We're looking at that, or even more possibly. And then that oxygenation. Of course, oxygenation. Remember, we talked about their sats are, if they're not COPD and their sats are dropping, put some oxygen on them for sure. We may even have to later intubate them just to support their respiratory. So we need that continued hemodynamic support. We need possibly corticosteroids. Those are anti-inflammatories, right? So a lot of these distribution shocks, there's an inflammatory response going on. An anaphylaxis is one that, we definitely need those corticosteroids. So you might see Solumedrol or methylprednisone or dexamethasone, any of the corticosteroids. And let's don't forget about GI and DIC. So often with the failing, as the liver fails, then sometimes we can see DIC, we can see problems with our glycemic control, but DIC is not a disease in itself. It's usually a problem, right? It's a response to a problem. So with SIRS and with sepsis and all, sometimes the patient will go into DIC. And infection can cause it, gram-negative bacteria, viral. There's a lot of different things can cause DIC. So regardless, we got to treat that underlying cause, and it's important to know your labs with this and to know the treatment for DIC. But I just wanted to throw that in there because sometimes with multiple organ failure, we will see those irregular labs. So as far as, they'll be doing ABGs, a coagulation panel, a CMP. We'll be doing lots of labs, a lactate, because as they get where, the shock progresses, as we go back to the stages of shock, their lactate can go up, and that's not a good sign. So definitely know your DIC labs. And let's talk a little bit about this tight glycemic control with your mods. What happens when your glycogen stores are all utilized by the body, and when the body uses up the glycogen stores, then it's going to start using its amino acids or its proteins to convert to glucose. And early in mods, our patients are usually hyperglycemic because they are using up all of this. As the liver starts to fail, and late in mods, the patient could become hypoglycemic because of that. So that's also a possibility. And then also remember your liver. There's a lot of clotting factors, and so the failing client is also at risk for DIC, so don't forget that. But let's talk a little bit about the GI, because early feedings are very important to protect the GI as well. With mods, or with any shock really, we're wanting to have that nutrition and metabolic support because of this problem with our hypermetabolic state. And with sepsis, we need the early feedings and nutrition because the GI tract, if the blood is shunning away from the GI tract, then you've got less blood in the GI tract, right? So if you've got, and the GI tract needs blood. It needs blood to digest food. It needs blood to have motility. So they're at higher risk for paralytic ileus, and they're higher risk for an ulcer or stress ulcer or an ulcer. So GI bleeding is common. We'll probably have to do some occult blood stools to make sure they're not bleeding. And also it contributes, all that lack of blood could contribute to some extra bacteria getting into the bloodstream. So this hypermetabolic state could cause the several different problems, as you can see. And then let's don't forget about proper ventilatory management. If they sometimes, as they begin to worsen, they will put them on a ventilator to help support their respiratory and help them to rest. So they would probably get some analgesics as well, sedation, because they're in this hypermetabolic state. So proper ventilatory management is so important, and all the things, the ventilator associated, preventing the ventilator associated pneumonia and all that. But we're trying to maintain that tissue oxygenation, and if they're in this hypermetabolic state, that's contributing to not maintaining the tissues, right? So that's what sometimes this ventilating them is kind of an intervention to help with that. Putting them on the ventilator, I think I said that wrong, but you know what I meant. So also, let's don't forget that a lot of these patients, a lot of the septic patients can turn into ARDS. Because of this inflammatory response, they can actually get ARDS, so don't forget that. And then I just wanted to kind of close it out with a collaborative care for all shocks, and just talk a little bit about what we do for all, for all of these. So in general, we want a quick diagnosis, and we want to increase perfusion, right? So whatever the reason, there's something wrong with perfusion, right? So we want to increase perfusion. And in general, we are looking at the ABCs: airway, breathing, circulation, right? And then also we want to protect the organs, and we do several things to protect the organs, such as early feedings and putting them on a ventilator. So we're protecting the organs as well. And then fluids, like I said, normal saline is a good one for all of them except cardiogenic. You have to be careful with cardiogenic. And often they will give like 2 to 3 liters, because we're trying to see, are they going to respond to the fluids, or do we need to go ahead with the pressors? And then your fluids, again, maintain that CVP 8 to 12, and possibly even more for hypovolemia, for absolute hypovolemia. And then your nutrition, definitely feedings within the first 24 hours, and if the GI is not working, then they might need parenteral nutrition or even central parenteral nutrition. Also, dehydration. Let's rule out dehydration. Fluid and electrolyte, we need to monitor those. Because remember I said they can have changes in level of consciousness with those fluid and electrolyte imbalances, and also with the so keep that in mind. And then as far as O2, we got to make sure they're ventilating. They need a patent airway. We want the O2 greater than 90. We want the PaO2 greater than 60. We need to vent them if needed. We already talked about that. And definitely ABGs. That's going to help us, right? Remember, it helps us to know ventilation and oxygenation, so definitely those ABGs. So this was just a little conglomerate to kind of help you know this is what we do for all the shocks, and kind of help close it down. But that's all I have. I hope this is helpful, and it will definitely help you. Definitely, read your book about your DIC. It is in a different chapter. NIP has a great handout, a great worksheet for DIC that you could review, and as well. But I would still suggest to read. I would suggest taking as many adaptive quizzing as you can. I do believe that is helpful, and making sure you read the rationales. And I did, there's also some great Khan Academy videos. They're like 10 minutes long, but they're great on all the shocks. They do a great job. They also have a sepsis one. So definitely use your resources, and I do hope this helps. And if you have any questions, if I said anything wrong or you question something I said, please reach out to me and send me an email or whatever. And I hope you have a great day.